Welcome everyone to the IPVS educational webinar series. This is the Q&A session which followed on from the session we had on HPV Behavioral Research and the 2030 targets. And I've hoped you've all had a chance to listen to that. This session is specifically on questions that we didn't have time to answer in that question. And as you will recall, it gives me great pleasure to introduce my fellow moderator, Professor Ellen Daly from the University of South Florida. And Ellen will be leading the questions to our four experts. And in that first webinar session, we had the privilege of hearing from our four researcher experts in HPV vaccination and screening. So again, a very warm welcome to Greg Zimmett, Erica Thompson, Joe Waller and Sue Sherman, who are here to respond to the questions that a lot of our viewers in that first webinar presented to us. So now I'm going to hand over to Ellen Daly, who's now going to explore those questions. Thank you.
Thanks, Margaret. So the first set of questions generally centered around the theme of vaccination. And the first question had to do with socioeconomic factors. And I believe that Dr. Thompson's going to address the question, economic challenges in HPV vaccine programs. Does cost of the vaccine pose a barrier to vaccination?
Thank you so much, Dr. Daly. So when we think about vaccine hesitancy, I go to the definition of the World Health Organization SAGE working group that has the 3 C's of confidence, complacency, and convenience. And that component of convenience reflects cost for vaccination or affordability within that definition. And so because of that, cost can be a barrier to HPV vaccination. And it isn't just the actual cost of the vaccine, but added structural barriers such as taking time off work or transportation or having primary care to get the vaccine. So we need to keep in mind that cost is a real or perceived barrier to HPV vaccination when conducting behavioral research. And some research, including some of Dr. Zimmett's work, has found that acceptability of HPV vaccination is higher if the vaccine is free compared to if it were at a cost or a fee. We also need to recognize that high vaccine prices may make it difficult for many countries to introduce HPV vaccination into their national immunization program. So overcoming cost barriers at a system level is critical to reach these HPV vaccination goals.
Thank you. The next 3 questions, I'm going to hand over to Dr. Zimmett and Dr. Waller. And these are all related to coverage factors. So Greg, could you and Joe take that first question, please?
Sure. So the first question is, how could developing countries increase their cover of vaccinations? This is certainly an excellent question. We know that low and low middle income countries in general tend to have lower HPV vaccination rates and are less likely to have national HPV vaccination programs. So one of the things that I think is important to look at is to look at those countries that have in fact successfully introduced HPV vaccination into a national program and have achieved relatively high vaccination rates. So a country like Rwanda, Malaysia are both countries that have introduced HPV vaccine nationally and have really good coverage. So I think those may be models that are worth looking at and finding out how did they do it, and as much as possible trying to replicate that. I think the other thing is obviously HPV vaccines that are currently available are rather expensive, and there are programs for reducing the cost of these vaccines through I believe Gavi and other organizations like that negotiate lower prices for low and low middle income countries. Even with the reduced cost, it can still be a challenge for countries that don't have sufficient resources to bring in the vaccine. So, my hope is that these vaccines will become more and more affordable. And I believe there are ongoing efforts to develop vaccines that will be less expensive and have less rigorous cold chain or delivery processes, so that they can more easily be delivered to low-income countries and into rural areas. So that will make a big difference if some new effective vaccines could be developed with that in mind. The other kind of work that's going on now is to reduce the number of doses. So there's a lot of research going on to look to see whether a single dose of the existing bivalent and 9-valent and 4-valent vaccines, if one dose can achieve reasonably good protection. If that's the case, that also reduces both the cost and the barriers in terms of vaccinating individuals in low-income and low-middle-income countries. Dr. Waller, do you have any additional thoughts?
Thank you, Greg. I think you've covered it for that one. Shall I move us on to the next question? So the second of the questions under the coverage factors is about whether the HPV vaccine is included in national immunization schedules in the US and Europe, and is it available for free? So I'll start with saying something about the UK, which is what I obviously know best, which is that it is included in the national immunization programme and has been for girls since 2008 and boys much more recently. It's offered through schools, free at the point of offer, and we have really high uptake rates, well over 85%. And excitingly today, we've just seen the first evidence published in The Lancet that this is now having a demonstrable effect on incidence of cervical cancer. That's the first time that that's been really clearly shown. So yeah, really encouraging. Most other countries in Europe do also have immunisation programmes. They don't all have a national health service as we do in the UK, but I think the vaccine is usually covered under insurance schemes so that it is free for people to have, although there are still countries where it hasn't been implemented, and gender neutral vaccination across Europe has been a bit slower to get going. So most countries still have a programme that's focused on girls, but increasing numbers of countries now also offering the vaccine to boys. Greg, I don't know if you want to say something about the US.
Sure. So the US is sort of complicated. The US is kind of like the European Union, but in one country. So there's tremendous variability from state to state. Their HPV vaccine is covered for all children through national law. So all vaccinations are covered for children up through age 18. So HPV vaccine is, there's no concerns there should be no concerns for any individual about having to pay for it. We don't have a national health service, and so how well vaccines are delivered and the particular policies vary from state to state.
Thank you. And the third question in this section on coverage, we'd like to also ask Dr. Sherman to join us talking about behavioral influences influencing low coverage of vaccination in Africa. So if Dr. Zimmett or Dr. Waller or Dr. Sherman have any thoughts about that.
I'm happy to start. And I don't know all of the details because every country is going to be different, and we have to sort of take out of the equation the availability of the vaccine. So that seems to me still to be the biggest barrier to the low coverage in countries in Africa. But again, there are countries that have been very successful, so they have been able to manage whatever behavioral issues there might have been, like Rwanda. And I think there's several other countries in Africa that have done a good job. I think anytime a new vaccine, it's not new anymore, but it might be new to a particular country, is going to be introduced, it's really important to understand ahead of time, in the communities where it's going to be delivered, what potential barriers or facilitators of vaccination are present. So I think that's true each country in sub-Saharan Africa or Northern Africa is going to be different in terms of culture and politics, and all of those factors need to be understood in order to ensure that a vaccination program for HPV vaccine is effectively implemented. Does anyone else have anything to add to that?
I think that's absolutely right. So I think doing bespoke research within a particular context to really understand what are the particular barriers and facilitators in both at a sort of individual psychological level in terms of health related beliefs and other psychological factors, and then the sort of social context and the cultural aspects, a bit like, well, the layer cake that Greg and Erica talked about in their talks. I think it's to generalize across the whole of Africa and say that there are particular behavioral factors is difficult, but I think it's really important to dig in to understand the local context ahead of, ideally ahead of implementation.
Any other thoughts about that?
No, I think Joe and Greg have covered that. I mean, when working with communities, I think it's always important to do stakeholder work with the individual communities in order to get at those personal behavioural levels that that Joe and Greg have referred to, and understand barriers, because although you might have the same ethnic background or religious background, we know that within communities those barriers can still vary even within those sort of broader groups. So that local stakeholder work is really important, especially if you're trying to build up trust in a particular community to engage with healthcare such as vaccination.
Which actually addresses, if you look on the slide, the 6th question, the role of religious leaders in HPV vaccination, considering issues of faith. So these two sociocultural questions are sort of in the middle of being discussed by all of you. If we could bring Dr. Thompson into this next question, to what extent does race and culture factor in vaccination in the US and the UK? If you have some thoughts about that.
Sure. So when I think about race and culture, I think we have a difficult time sometimes understanding the heterogeneity of different racial or ethnic groups based on the way national surveillance data may be collected. So here in the United States, we look at national surveillance data among adolescents getting the HPV vaccine. And we see that historically underrepresented minorities and ethnic groups are actually more likely to be vaccinated compared to their white counterparts. And in some ways, we've seen that the white, affluent, educated parents are the least likely to get vaccinated. So I think that's one layer if we're talking about race and culture. But if we are to dig in more into the cultural aspects around HPV vaccination, I would echo what the other speakers have shared, that we really need to investigate the attitudes, beliefs, and behaviors within subsets of cultural backgrounds and have an intersectionality approach to that as well. From a behavioral science perspective, we need to continue to develop and test interventions that are culturally appropriate and tailored in order to improve HPV vaccine uptake. So some examples in the United States have been programs that use photonovellas or interactive media with lay health workers to improve HPV vaccination among Hispanic families. So really getting at those core beliefs and attitudes around HPV vaccination and using culture-centered narratives may be important to move the needle forward in certain cultural groups.
Okay, so the next set of questions have to do with screening. And the first is related to socioeconomic factors. And I think this is a question that Dr. Sherman's going to address. How can HPV screening be increased in the low-income countries?
Thank you. So there's not really a one-size-fits-all answer to this question. It really very much depends on existing healthcare infrastructure, the geographical makeup of each country, for example, how urban, how rural it is, local religion, culture, and so on and so forth. But taking those things into account, looking at a sort of broad level, HPV self-sampling may offer one route to increasing HPV screening. For example, being able to post those kits out to women and have them posted back again obviates the need for sort of local clinics and so on and so forth. Mobile screening units might be another opportunity, but it will vary very much from country to country depending on the local situation. And as Joe and I discussed in the presentation that we gave previously, there is a recent paper by Wu and colleagues in Preventative Medicine earlier this year, which talks about low, middle and income country responses to COVID and how this might provide opportunities for embedding HPV screening within some of those countries that perhaps don't already have that available. Joe, was there anything you wanted to add to that?
I think, yeah, that, not really, but I think it's almost the same answer to the question about vaccination, is that, you know, as well as making sure that the screening offer is in place. So if you think about the COM-B model of health behaviour that we often use as a sort of framework for thinking about the factors that have to be in place for a behaviour to be enacted, you've got to have the opportunity, so the screening offer has to be there, but you also need the capability and the motivation. And I think trying to understand what the potential barriers in terms of people's understanding or their beliefs about screening and their motivation in terms of perceived risk and other factors is important. And to do that, again, as for vaccination, in a really local context, to try and understand, you know, what the situation is within a particular community where screening is being implemented, or where the efforts are being made to increase uptake, to try to be able to tailor efforts to whatever the barriers in that context are.
Thank you both. So that was a question that addressed socioeconomic factors in low-income countries. We have a couple of questions about sociocultural factors, and I think all of our speakers can address the issues in the US and UK. To what extent does race and culture factor in screening in the US and UK? And can we start with Dr. Thompson, Dr. Zimmett in the US?
Well, I think in some ways it mirrors what we've already discussed with HPV vaccination in terms of culture and being, understanding the cultural attitudes and beliefs related to screening. I know some work, for example, among migrant farm workers and women who've been screened for cervical cancer, and having beliefs that if they screen with an abnormal PAP, that they have a belief that they're going to die and may not continue on with care. So really understanding what those beliefs are within a community so that the proper health education and counseling can occur in order not only to have screening occur, but also to have follow-up care if there is any abnormalities with that screening.
I might just add, in certain cultural settings, there may be a great deal of stigma about screening and the potential, you know, what does it mean to screen positive for HPV, particularly for those who know that HPV is largely a sexually transmitted infection. So stigma can also play a role. And as we talked about in the webinar, we talked about the issue of the feminization of HPV. So that puts particular burdens on women in terms of bearing the societal stigma around abnormal PAP or an HPV diagnosis.
Thank you. Dr. Waller?
About the work that we've done in the UK on this. So my colleague, Dr. Laura Marlowe, has done a lot of work looking at differences in attitudes to screening among different ethnic minority groups. And I guess there's a range of factors. So at the most basic level, we found that women from ethnic minority groups are least likely to actually be aware of the offer of screening in the UK, even though we have an organised call recall programme. And that may be as basic as language issues. Women whose first language is not English may not engage or be able to engage with the information that they're sent. Then there are a range of psychological factors. We know that cancer fear and fatalism tend to be higher among certain ethnic minority groups in the UK. There are more prevalent beliefs, for example, about the need, sort of lack of understanding about the need for screening, even in the absence of symptoms. There are issues like those that Greg has just mentioned in relation to the sort of cultural acceptability of being tested for a sexually transmitted infection, and in some communities that may not be acceptable, for example in unmarried women, because even attending for screening may convey an unwanted message about being sexually active. And then we know that, again, for some groups, having the possibility of a male doctor or practitioner doing the smear test may make it unacceptable. So making sure that that offer of knowing that the smear taker can be a woman can be helpful. We've done some work, again, Laura did work looking and finding that people from ethnic minority groups in the UK have a preference for a strong recommendation to take part in screening from the NHS, and which is somewhat at odds with a move towards a more informed and sort of informed choice approach. So just making sure that screening materials and the way that we offer screening is done in a way that doesn't disadvantage certain ethnic minority groups. And then there are very specific issues, for example, female genital mutilation, which there's been a nice study in London of the Somali community finding that there are very particular barriers that places on women from certain backgrounds. So I think there's a whole range of different factors and a need to really, again, look really carefully at particular groups and develop very tailored interventions. Sue might want to add.
Yeah, just a couple of things to add. One example from the UK is another group, in addition to the ones that Joe has talked about. We'd looked at some work with migrant Eastern European women. And what we find with those groups of women is that some of those women actually prefer to go back to their country of origin in order to have screening and engage with gynecological health generally. And that might be because they come from a country where that's offered on an annual basis, for example. And so there's a lot of work there to be done, kind of building trust with those communities and explaining the reason for the kind of the screening intervals that exist in the UK, for example. I just wanted to mention another example as well, actually outside of the UK and the USA, which is from New Zealand. So I collaborate with a group of colleagues, including Karen Bartholomew, Colette Bromhead and Anna Maxwell, amongst others, in New Zealand. And they're working to address the health outcomes for Maori women associated with cervical cancer. Maori women have a 1.7 times higher incidence of cervical cancer than non-Maori, and the mortality rate is 2.7 times higher. And so we're doing work to explore the role that HPV self-sampling, which I talked about earlier, may play in reducing the incidence and mortality rates. And again, this issue that I mentioned earlier in this session about stakeholder engagement. So key to this work is really understanding the needs and preferences of the community, as Joe's just said as well. And in this particular example, it can be even those sort of structural things or sort of practical things, such as understanding if they prefer to collect a self-sampling kit or have it posted out, and how they prefer to return it. So when we're thinking about behavioural science and understanding engagement and increasing it, it's important to look all the way through the process of engaging with screening, even down to those sort of practical barriers.
Thank you. And I leave this one open to all four of you. The last question about the role of religious leaders in HPV screening, considering issues of faith. Is there anyone who'd like to add some thoughts about that?
The only work I'm familiar with is, sorry, Greg.
Oh, why don't you go ahead and start?
Well, I was actually going to say the only work I'm aware of around engaging with religious leaders actually is around vaccination rather than screening. So, so over to you.
Okay, yeah. I mean, I think, you know, maybe it's an open question whether religious leaders might have a positive influence potentially on HPV screening. Certainly with vaccination, it can only be helpful. Any kind of community, cultural leader, religious leader, I think if they can be open and encouraging about vaccination and screening, it can only be helpful. There are virtually no religions that have any writings that oppose any kind of vaccination. So, people often bring up religious exemptions as an issue. In fact, there are very, very, very few religions, and certainly none of the major religions that that say that vaccination is not allowed. So it's really helpful when religious leaders are very clear about this, and I know I think it's made some difference. The Catholic Medical Association came out in support of HPV vaccination quite a few years ago, and those kinds of messages can be very influential, I think, for some people, particularly if they're sort of not sure whether they should go forward with it or not, and they look to these kinds of leaders for guidance.
So maybe, Greg, when you're saying that there aren't any major religions that ban vaccination, if we were to include screening in that, maybe we could talk about sort of broader messages just about HPV prevention. So you could talk about primary prevention with vaccine and secondary prevention with screening, and that might be a nice approach.
That would be great. And I see a future research project for someone.
I do.
For someone either on the panel or maybe listening in.
Okay, so thank you very much. The next set of questions that we had have to do with education. And the first question, again, dealing with socioeconomic factors, I believe we're going to ask Dr. Waller to talk about what device was used for self-sampling, and did you train and educate women prior to doing the self-sampling screening?
Thank you. Yeah, I'm not quite sure which study this question was specifically asking about, but there's a range of different devices that have been used for self-sampling, most commonly a flock swab, which is just like a long cotton bud, but there are other sort of, I guess, less simple or more devices that have been developed, brushes and different ways of getting a really good sample for HPV testing. And there's a really nice review that's just come out. I just came across it this morning preparing for this, by Nishimura et al. In BMJ Global Health, which is a systematic review pulling together lots of studies on self-sampling from around the world, and looking at the acceptability of different devices. And broadly speaking, most devices seem to be acceptable, and there's not a sort of standout winner in terms of self-sampling. The big U-Screen study that's being done in London at the moment is using a flock swab, and the screening program in England is currently evaluating 3 different self-sampling devices for a possible future pilot of self-sampling, one of which is the flock swab. And then there's the Aptima multi-test swab and the Evelyn brush. So it will be interesting. We'll be able to see in that validation study whether one comes out as being more acceptable and easy to use than the others. And in terms of training and educating, I think it's really important to have very clear instructions with lots of pictures, so that even if women have low levels of literacy, they can see what they need to do. Most women report finding it very easy. Some appreciate having the option to talk to a health professional and to ask questions if they're not sure. And again, the U-Screen study in London at the moment has some really nice video animations which people can watch in order to see how to do it if they're not sure. So I think it's a case of really good instruction materials, access to someone that people can ask questions to if they're not sure. But generally, it seems to be a very straightforward and acceptable thing for most women to do.
And we have a related question that I would open to any one of you. Will educating schoolgirls have long-term improvement in HPV vaccination and screening? And just your thoughts about the work that you've done and what educating schoolgirls might have, the effect that might have.
Shall I start on this one? So I think in terms of cervical screening, educating girls is certainly one part of the approach that is needed, especially since there's actually some evidence that some girls may think they don't need to be screened if they have been vaccinated. However, in the UK, women aren't invited to cervical screening until they're 24 and a half. And girls are vaccinated against HPV when they're 12 or 13. So there's quite a long gap between the two. And so although educating girls is important, I would suggest that the main focus for screening should actually be on young women. And it's also worth noting that we know from behavioural research that increasing knowledge on its own is unlikely to be sufficient to increase screening, and that other barriers need to be addressed as well. So we've talked about some of the communities that are important to focus on, and I would say that sort of work with those underserved communities, for example, with disabled women, to understand the barriers they particularly face would be useful alongside increasing knowledge. But increasing knowledge is never a bad thing. So I think that would be useful for across the lifespan, to be honest.
Thank you, Sue.
I would, if I could follow up on that a little bit also, and sort of step back. So one thing is, I think it's really important to educate school boys as well, particularly around vaccination, and about as part of that feminization issue, how to push back on that. Even in countries that don't have gender neutral vaccination, I think it's important that boys understand that girls don't get HPV out of the sky. It just doesn't appear. That boys have an equal responsibility, or even more responsibility, for infection and transmission. So I think that's really, really important, and that should start relatively early on. The other issue, and this is where I'm going to step back a little bit, is I think, speaking of the United States, I think we do a very, very poor job in terms of educating children about critical thinking, health literacy, what I call vaccination literacy, maybe screening literacy. But all of these issues are relatively ignored in most of our school systems, and lead, I think, often to adults who don't understand why they're being asked to do what they do, and don't understand how vaccines work. And it leads to all sorts of problems, which we see in the US now with COVID vaccination, with all sorts of mythologies around the vaccine being promulgated. And I think we could do a much better job of educating both boys and girls about HPV, about health in general.
I totally agree with what Greg has shared, and the importance of how policy intersects with behavioral science as well. So sexual health education in many states in the United States are dictated by state standards or local school board standards. So having integration of this health literacy and vaccine literacy within that type of education is also critical, to be sure that it's a standard that is available for all boys and girls in schools.
Great. Any other thoughts? Well, we have an interesting question that was submitted having to do with coverage factors. And the question is it possible to drive HPV vaccination in the same manner as COVID-19 vaccination in terms of being driven globally, considering the fact that global coverage of HPV vaccination after all these years is just 15%? And we're wondering, and Greg, I think we're going to start with you.
Okay. So first, I want to say that although COVID vaccination has been ramped up with breathtaking speed, I mean, it really, really impressive, we're not there yet. And a lot of low and middle income countries have no COVID vaccination going on, or very, very little. So it's impressive how quickly we've been able to ramp up COVID vaccination, particularly in high income countries. But considering that SARS-CoV-2, the virus that causes COVID-19, is a contagious respiratory virus, it doesn't respect borders between states, between countries. So I just want to put a plug in there that we still haven't done the job with COVID-19 vaccination, and we really need to do a better job with that. Now, we certainly have done better faster than with HPV. So is it possible? In theory, it's possible. But the difference, one of the key differences is this is a pandemic crisis with COVID-19, and HPV is not a pandemic, and it doesn't have the same, it's not viewed as a crisis in the same way. So because of it's a respiratory virus, easily transmitted, huge amounts of resources were brought to bear in high-income countries for developing and implementing, disseminating vaccination. Even though it's possible that those same resources in theory could be directed towards HPV vaccination, I don't see that happening. So I think, on the other hand, I think we might look at how we've promoted COVID-19 vaccination, and maybe there's some of the infrastructures that have been developed and are being developed to deliver COVID-19 vaccine, that we could use those existing kind of policy and practical infrastructures to try to drive up HPV vaccination as well. Does anyone else have any thoughts?
I think that's right. And I think especially, I think your last point about using some of the things we've learned about COVID vaccination and sort of applying that to other vaccines, be that HPV or other things. And I know in the UK, there have been initiatives like going out and delivering the COVID vaccine in mosques or in local community centres, making it coming to some people's communities rather than expecting them to go somewhere unfamiliar and potentially less culturally acceptable. So I think some of those lessons learned can hopefully help in different contexts to increase HPV vaccine coverage as well.
That's great. Thank you very much. And just moving on, so we can get to our last set of questions. The theme here is epidemiology and research. And there's a question that I think we're going to have Dr. Zimmet address first in epidemiology. How about the issue of the HPV strains that these vaccines don't protect against? And could you address that?
Sure. So it depends on which vaccine you're talking about. So obviously the bivalent vaccine, there are far more strains that it doesn't cover. Nonetheless, it covers about 70% of the types of HPV that are responsible for cervical and other cancers. And that percentage it varies from location to location, but it's pretty close to 70%, pretty much globally. It'll vary a little bit. The quadrivalent or four-valent HPV vaccine adds in those two types that protect against 90% of genital warts. So the protection against genital warts in the four-valent vaccine and the nine-valent vaccine are the same. It's about 90%, which is really impressive. So it has the same two cancer prevention types, type 16 and 18 as the bivalent. So it has the same sort of coverage, about 70% or so. The nine-valent vaccine covers 5 additional cancer-causing types. And so coverage is up to, in that case, in terms of cancers, preventing another 10 to 20% of cancers. So it's 80 to 90 in that range of coverage. So the nine-valent vaccine actually protects against the vast majority of HPV types that cause cancers. There's still a few types that it doesn't cover. Part of the issue is that as you add more, each additional type adds a smaller and smaller fraction of protection. And so, and it costs, as you add more types in, it has to be retested, and it costs, that you have to look at the kind of cost of very small increments in protection versus having to run big clinical trials to test it out. So even with the nine-valent vaccine, there are going to be continuing cases of cervical cancer that the vaccine doesn't prevent. And that's why we continue to need screening. So, with really effective screening programs that the population, the women use, and particularly the 9-valent HPV vaccination, we really can eliminate cervical cancer, essentially reduce the incidence of cervical cancer to very close to 0. But it still was going to take both of those approaches. Any other thoughts?
That was a very thorough description of the vaccines and how they've been developed and why these strains are covered. So that helps quite a bit. We have a question under the sort of sub-theme of research. We've sort of addressed this a little bit, but it came up in a couple of different questions. And again, it's how to deal with, in this case, research, HPV research being rolled out in African countries. I think we've talked about vaccine and screening. Are there any thoughts about research being conducted in African countries?
I think I'm supposed to start this off. Again, each country is going to be different. In Africa, and there are countries where, I'm going to speak specifically to behavioral science research. There are countries where behavioral science research around HPV is ongoing. I'm familiar with Kenya because Indiana University has a partnership program with Moi University in Eldoret, and there have been and continue to be projects related to HPV and cervical cancer that do have a kind of behavioral component to them as well. I think it may require in some countries a partnership between countries. It depends on the resources available to conduct behavioral science research. In the study I was talking about in Eldoret, it's that there's this kind of partnership between University of Moi and Indiana University in the US, which is the point of which is to really provide the kind of training needed for individuals in Kenya to be able to do a lot of this research independently. And I think that's really where we want to go with this kind of research, is to have research in African countries done as much as possible by people who live in African countries. That can be sometimes enhanced through partnerships with researchers in other countries that have particular skills that can then be transferred to individuals in the African countries. I don't know if anyone else has any other thoughts on this.
I think you covered it nicely there. Thank you, Greg.
I did too. And finally, a question came up about research articles that are quoted in the presentations. The person writing the question asked, are they easily accessible or does one need a subscription? And Greg, I think we're going to ask you to start that answer. No?
No, it's going to be me this time, I'm afraid.
Oh, I'm sorry.
That's okay. We switched earlier. So thank you to the person who asked this question. So we've quoted quite a lot of research articles, and some of them will be available open access. Some of them are going to be available through the libraries at your institution. And if you have any difficulty accessing them, we would strongly recommend you contact your supervisor or library to see if they can arrange access for you. But this also gives me an opportunity to just flag open access journals and making research more open. Increasingly, a lot of the research that we're doing is either submitted to preprint servers before it's published, or it is published open access through journal schemes. And so this enables research to be disseminated more quickly than a traditional route, and also to be more widely accessible. And I think that's something we're going to see more of as we go on. So hopefully you'll be able to access the articles that we have talked about and cited, but as I say, do contact your supervisor or library if you're unable to do so. Did anyone else want to add anything to that?
That's great, Sue. Thank you so much, and sorry for the mix-up. I believe that's all of our questions for this session. Margaret, you're muted. Margaret?
Thank you, Ellen. And on behalf of the International Papillomavirus Society Education Subcommittee, I just cannot thank Ellen, Greg, Erica, Joe, and Sue enough for the very generous time they've given. At the end of the webinar, we just felt it really important that these questions that you've taken the time to give us be addressed. I'm hoping you've found this question and answer session valuable. And of course, we've got the conference coming up in just a few days, and there's some really fantastic behavioural research also going to be presented as that. Sadly, you've missed the early bird, but if you haven't registered, I'd highly recommend that. Behavioural research is the engine of implementation, and as Joe was, showcasing the fabulous success of the start of the elimination of cervical cancer that we're seeing in the UK, that are very impressive results in the Lancet this week. And it's only with behavioural research that we can really understand what populations want. So on behalf of Mark Stebbin and the Education Subcommittee, sincere thanks to you all, and Ellen for that wonderful facilitation of the questions. So that's the end of our session. We look forward to seeing you back in 2022 when there'll be more behavioural webinars. Take care until then. Thank you. Hey.